morning's Breakfast at Sky seminar series. I'm really looking forward to this presentation today. I had the opportunity to meet Jane a few weeks back, and she kindly agreed to join us this morning to talk about wound risks and how PT and OT can be involved. So before I turn things over to Jane, just a reminder, we're going to be recording this session and then it will be up on the website shortly afterwards. Hoping for we'll have quite a lively discussion with Jane about our role and how we can identify and measure the pressure injuries that we see. So we'll be taking questions at the end. So if you feel comfortable, please unmute and chat with Jane directly, and that part will not be recorded for posting on the website. So to begin, I'd like to start with a land acknowledgement. So the RCC and Sky Center are located on the original lands of Anishinaabe, Aninawak, Athinawak, Anishinaabe, Dakota, and Dene peoples, and the homeland of the Métis Nation. We respect the treaties on these territories. We acknowledge the harms and mistakes of the past, ongoing injustice, and the pain of the present. We dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So as I mentioned, we have Jane McSwiggan here to talk to us today about wound risk and how it's always a puzzle and where OT and PT fit in. So Jane is an occupational therapist by background and the education and research coordinator for wound care for the Winnipeg Regional Health Authority. She is responsible for the administration of wound care courses and development of best practice for wound care. Jane has a tremendous team of wound care specialists to call on to develop content and teach the courses. She enjoys working as a resource to the healthcare community for problem solving, networking, and connecting with people, with each other, and is thrilled that she can make someone's day a little bit easier. And I can attest to that. So a few weeks ago, Jane certainly made my day much easier by assisting me with one of our guidelines that we're currently developing on the on pressure management for wounds. So thank you so much for joining us today, Jane, and I will turn things over to you.
Good. What a great pleasure to be able to reach out and chat with you this morning. So I'm hoping that the presentation is fairly informal, and I'm hoping that we have some discussion as well, because I certainly am not any kind of expert in the types of conditions that you see. So I need your help on that one. So this was something I thought a little bit about for this presentation. Wound risk is always a puzzle, and I think that's where I'd like to kind of take us a little bit today. And the reason I'm doing that is because there's so many aspects to wound risk. So there's things like our scope of practice. Do I, as an OT or as a physio, do I know where I fit in the team? Do I think that maybe it's something my nursing colleagues are better at? Do I have the confidence? Where do things like ADL and mobility fit, and equipment, and things like moisture and incontinence? So we start with this kind of puzzle, and so you think about that when you talk with your colleagues and talk about wound risk or wound care. It's pretty hard to find your way around it. So hopefully today I can help you with a few ways to think about where you fit. So this is a little bit of probably what you've seen before. It was sent out for the intro to this particular presentation. And so, I mean, your role is very significant. Things like wound prevention, identifying and treating the cause of the wound, treating person-centered concerns, managing edema sometimes, and interprofessional practice. So there's lots of things, and this is just a few things that might be things that you can do in your practice. So a little bit today, I just wanted to talk a bit about the skin and recognizing and managing risks for wounds. So I starred a couple of things that I had in the initial objectives wound types, because I thought I don't know what they are for you folks. Staging pressure injuries, and then sort of discuss connecting with wound care teams. And I think that's very individual depending on where you are. So You've got my biography. So just a little bit more about this position. I have the privilege to be the first person to hold the position of Education Research Coordinator for wound care. And it's been sort of a nice departure for the portfolio that I work in, because up until recently it was all the other team members were nurses. I now am managed by a physio, so it's really cool, and I'm part of the collaborative practice portfolio within WRHA. So it's evolved quite a bit in the almost 7 years I've been in this job. So I know Liz had talked a bit about the fact that we wouldn't have time. Well, we might talk about questions at the end, but if there's a small number of people, maybe if there's anything that you want to think about now, and tell me a little bit of something you would like to learn or a question you'd like to ask. So if there's something that's sort of burning, please introduce yourself and tell me something that you'd like to learn or a question you'd like to ask. Okay, so we'll leave that maybe long to the end, and that's fine. One of the things that I've talked a bit about in the whole area of wound care is this whole piece about whether you're sort of a generalist versus a specialist. And I think it's often a question that comes up when we work maybe more in isolation from other teams. So what I'm thinking about is you're an OT or a physio, and you might be the only person that's going into that person's home or providing that person with service, depending on your practice setting. And I think that's always, where do I fit? Where do I fit with wound care? And so we have, obviously, in our wound care teams, we have specialists. We have people that are called advanced wound care clinicians, and that's all they do all day. But you have an OT or you have a bedside nurse who has to do a lot of other things, right? So where do we fit? So I wanted to talk a little bit about that, sort of where that fits for you. I think when you talk about folks like yourselves who are more like extended generalists, so you are really applying a very full scope of practice. So you might be doing a lot of stuff. You might be doing developmental things, but you also may be working in a situation where you have to be able to do seating. So you have a broad scope of practice. You have to, it's very essential for you to maintain your competence. You need to access to professional support. Sometimes you are mentored in a larger center. You might come back to your larger center for mentoring, or you might go to another larger center of excellence for mentoring. You need to be very culturally knowledgeable and a community member in many ways. And you need also financial support and access to technology. So this is sort of the role of an extended generalist. So sometimes this happens to folks who work rurally. And I also think if you work within a fairly specialized area or not in a big center, such as say Health Sciences Center, you really are an extended generalist. And sort of a blending of the two, right? So sometimes when I talk, and this is kind of the context of wound care, when I talk to our staff, the nursing staff I work with, they sort of say, well, I'll defer to the advanced wound care clinician for something. And really, you need to have that sort of expert and your local knowledge, which is your own knowledge, must be equally valued. Expert knowledge is always privileged, but genuine power sharing in a participatory process can challenge this. So we need to think about, I will need to go to an expert, but I also have my own level of expertise. And then communities and organizations should not be expected to operate in similar ways. And I think healthcare sometimes is very black and white, sort of show me the way to do this and I'll continue to do it. So these are just some little words I find that are helpful to think about, maybe some practice change or sort of where you fit in your setting. Again, just from my perspective, sort of building a case for wound care, really part of my job is to build capacity, and we don't have capacity built and a really good example of this is flying people in from up north for treatment. So clients tend to go to tertiary care centers for advanced treatments. We also have a lack of consistency in wound assessments. We have trying really hard to get our best practice in terms of wound assessment. So we're all talking about the same things. And we've got very fragmented systems, and I don't need to tell anybody who works in healthcare about how that works. And we also still have to be doing more with robust technology. And unfortunately, the pandemic has sort of helped us a bit with that. Now I can consult with people outside of the city. I can chat with people in Churchill. And so I've been able to do a little bit more of that, which has been really neat to do that. So building capacity, what we're trying to do is actually build more advanced wound care clinicians in areas like Churchill and the Flin Flon, and that's been just something we've more started in the last year or so. So hopefully that's helpful for some of your work as well. Excuse me. I think we're talking about roles in a new area. I think practice change is really hard. Sometimes it's that lack of confidence in wound assessment, fear of doing harm. So, should I take that bandage off? Maybe I'll do something wrong. There's a lot of knowledge and assumptions about wound care, unfortunately. Excuse me. I'm always trying to work through those a little bit with my nursing colleagues. Oh, well, we'd always do it this way, Jane. We have never done it that way. And I'm like, well, it should have always been done that way. Somebody learned it kind of the wrong way. Scope of practice, we don't actually need any wound care orders. In WRHA, we have that in our policy, but still people struggle with an order that gets written about doing something. I talk a lot about this lack of mature culture for safety, and I'll talk a little bit about critical incidents as well in the presentation. So what I mean by that is that we're still kind of, if we do harm or we perceive that harm has happened. So harm could be something like a fractured boot causing a pressure injury. We tend to be very nervous about that. And oh my goodness, we caused harm. Sometimes we cover it up. Sometimes we don't talk about it. And so healthcare unfortunately doesn't have a very mature culture for safety. If we compare ourselves to other institutions, for example, like aviation, where it's sort of a zero tolerance rate, you expect the plane not to fall out of the sky, but when we travel, but unfortunately, when we go into a healthcare facility, we have a high probability that we're going to get some injuries. So that's sort of something we have to work on, and wound care really falls into that category a lot. And then we have these sort of disjointed systems in finances, again, as you know about. So making that change is very, very hard. So I'd like to talk a bit about the skin, and I'm kind of passionate about the skin because it is the largest organ in the body, and the reason it's an organ is because it protects us. It has regulatory functions, and it also is obviously the big organ of sensation. The way I talk about the skin sometimes is I bring it to people's attention that, maybe those of us who, well, more if you're in a nursing setting, but a nurse or a doctor doesn't think a lot about putting in an IV or giving an injection. But if we think about another organ in the body, if we think about any of the internal organs like the heart or the liver, we would never do that to that organ without a lot of, being in a lab and a lot of important people around. So sometimes the skin gets kind of shafted a bit in terms of it being an organ, and it's still as important as all of the other organs in the body. So just a little bit about cool stuff. So I'm just going to talk a little bit about the function of the skin here. So one of the things that the epidermis does is it actually, that we've got this tight junction at the top, the stratum granulosum. It has these very tight junctions, so we actually don't leak, right? Unless there's a breach in the skin, we don't leak. So wounds will leak because there's a breach in the skin. And the skin also doesn't take on any water, because we have this matrix of the stratum corneum, which is at the top layer, is impermeable. And it's really important to think about the skin pH being acid. So we have this acid mantle around us. And the reason we're acid is if we weren't, bacteria would invade us. So this is a really important thing to think about when you're talking about moisture in skin. So we'll come back to that in just a little bit about moisture associated skin damage as a risk for wounds, because I'm sure that's something with your population you will see. So the epidermis, or the dermis, I'm sorry, is sensation, circulation, temperature, excretion, lubrication, strength, and flexibility. So the dermis contains all of our nerves. It contains blood vessels. Blood vessels will keep us cool, keep us warm, excrete sweat. Lubrication is our sebaceous glands, and the strength and flexibility comes from the collagen and the elastin. So as a skin is very immature, it's not very strong. And then obviously when you work with the aged elderly population, we have that lack of strength and flexibility because the collagen decreases and becomes less strong. And then the hypodermis, or the subcutaneous layer, is really our thermoregulation. So this is what keeps us warm, cool, because it has that sort of the fatty layer. It's the body's thermostat. So it actually figures out whether we're getting too hot, and then it'll send signals to the dermis to open up or close down the blood vessels. Protection. So we all have probably worked with kids or adults that are very thin. They don't have an intact subcutaneous layer, and they're much more prone to injury. And then it also connects the dermis to the muscular fascia. So it's kind of important to think about the layers of the skin because they're really important when you come to staging. So question, what creates wound risk? And really the answer is the disruption of the function of the skin. So if we disrupt anything that the skin does, we lose protection. So things like pressure, mechanical forces, trauma, circulatory issues, and pathologies. So any of those things will create this risk. So what's really important when you're looking at risk is you have to consider all of the things that are disrupting the function of the skin. And that can, again, create that sort of puzzle that we have to work through. What's really important is always investigating the cause, because really the cause determines your intervention and your treatment. So I often get called to my desk. I do a little bit of wound consultation because I am also an advanced wound care clinician. I do have my certification in wound care. And often I'll get a call to my desk saying, Jane, this wound is not doing very well. And I sort of have to say, okay, so we need to peel back the layers here. You need to tell me, what is the person bringing to the table? What are the conditions that person has? What are the things that you're doing to them, perhaps in terms of a treatment, or do they have, a medical device, or what is it that is causing this wound? Are there medical conditions that are causing this wound? Because we have to pick all those out first before we can determine what we can do. So often the question from the nurses is, what dressing do I put on the wound? So we really have to sort of backstep quite a bit in order to do that. And I generally find that when people are struggling, they've missed a piece of that. They've missed something that they haven't thought about. So it is like being a bit of a detective when we're looking at the cause of a wound. I'm going to just introduce you to the wound bed paradigm, which is really our best practice. We're kind of struggling to bring it into our region. If anybody's attended the level 1 courses or any of the level 2 courses we do, we talk about it a lot. Now, I'm not going to talk about the whole paradigm, but I'm going to give you parts of it that are really pertinent to your practice. And so basically the top part here, you've got your child or youth who has a wound or is at risk. So I've already mentioned identifying and treating the cause. So that's really important. We also need to look at the person-centered concerns, so person-family-centered concerns in your situation. And then we also need to think about whether this wound or this risk is something that's going to be healable maintenance, where this person's always going to have to live with the wound may not heal particularly well because you can't, for example, offload it. You can't change their nutrition. You can't change certain things. Or is the wound kind of not going to heal at all? Or if you've got somebody with a palliative diagnosis, right? So one of the things we don't do very well in wound care is we don't really talk about that. And again, I kind of make a parallel between wounds, say, and cancer. So if somebody has cancer, we never just say, oh, we'll just try this out for a little while and see how it goes. And that, unfortunately, is the reality with wound care. We sometimes see wounds that are very old, and the same thing's being done with them for many, many months. And so that's a big practice change we need to make, is to say a wound needs, if it hasn't really changed within 2 to 4 weeks, we've missed something. The bottom part of the paradigm is really something, if we can have another discussion at some time about how you would employ some of these areas in terms of looking at the kind of tissue in the wound, whether there's a need for debridement of necrotic tissue. Now, some of our OT and physio colleagues will do some of this when they work in hand injuries. We'll actually debride out tissue, and then we need to look at whether the wound's got some infection. Moisture balance is an interesting piece, because it's the wound can have moisture because of the outflow or the exudate from the wound, and also there may be moisture that's ambient around the wound from incontinence or for sweat and things like that. So it can create a very moist environment. We got to get that moisture balance right. Or in this situation where someone's diabetic, we may have a very dry wound, and we need to get it moistened more. And then the edge of the wound is something we have to think about, because the edge of the wound doesn't close if it doesn't have a healthy edge. So again, these are things that are really important to look at when you do have a wound, but I'm just going to focus on the top parts that I've sort of circled for you, because we're talking about risk in this presentation. I've kind of talked about this a little bit, but when we have a loss of protection, our acid mantle is disrupted and the skin becomes alkaline. So what happens with that is it becomes pervious to moisture. Bacteria can penetrate and we can get infection, and the skin breaks down. So these are things like that can happen when somebody's incontinent, when somebody is very sweaty, or when somebody has saliva. They may drool and they may have skin breakdown, or somebody who has a contracture and you get the moisture buildup in the contracture. So these are all things that will cause the skin to break down. Just on that sort of note of moisture, you may be familiar with the condition called moisture associated skin damage, or MASD. And it has kind of three forms. So we have maceration. So that's when you see that white tissue. It happens with wound exudate, saliva, mucus, perspiration. You can have incontinence associated dermatitis, which is kind of like a diaper rash, really, in many ways. So urine, stool, and also includes anybody who's got an ostomy. The tissue around the ostomy can become quite excoriated, and that's incontinence associated dermatitis. It's important to distinguish that from pressure injuries. They're a little bit different. Incontinence associated dermatitis is always very diffuse. Pressure injuries are rather specifically round and over a bony prominence. And then ITD or intertrigo, where you get perspiration trapped in skin folds. And so if somebody's got some skin folds because they have a pannus, sometimes people will get skin folds when they're sitting. Sometimes their skin folds will change when they're lying down. So when we're talking about skin folds, we need to look at people in all of their support surfaces, and they can get shearing on their skin because of that. Moisture management. So I think this is really an area that OTs and physios can really look at. Meticulous skin care and regular toileting. So obviously with children and youth that have continence issues, that can be very challenging. We do suggest, and I'm not sure whether it's common practice for you, that you, as part of self-care for people that have incontinence or moisture issues, where the skin is intact, you can use a barrier cream. And so unfortunately, I rushed away from the office yesterday and I didn't bring samples, but the WHA contract has something called Criticade Clear, and certainly can give you that information afterwards on intact skin. So really, as a complete blanket, anybody with incontinence needs to have a barrier cream. Well-fitting briefs and all of those things that might manage incontinence are very important. We do have a dressing in a tube for broken skin. It's called Triad. It's basically a dressing that contains a fair bit of zinc oxide, and it does actually help with broken skin. Really important to think about investigating and treating incontinence, if possible, with moisture from skin folds. We have a product that does that. It's called Intradry. So again, I can walk you through some of that, and then exudate and saliva and moisture on any of those things, you know, as best as possible, controlling those. And sometimes that's really, really, really challenging. But thinking about moisture management definitely as a part of self-care is quite important. This is just something from the CLWK. It's an awesome website. It's out of BC, and it actually has quite a bit of information on moisture-associated dermatitis. It sort of defines it, so that's something I just will leave you with for the future. And obviously the things that we're probably more familiar with in terms of trauma to the skin, so pressure, right? So it's kind of important to think about the fact that you've got this pressure that will actually cause the blood vessels to collapse. Blood flow stops, which results in tissue damage and death. So when I read that the first time round about pressure injuries, I thought that's incredibly dramatic, isn't it? And so it's very scary. So we need to even think about a stage 1 pressure injury. We still have tissue damage, right, happening with that red mark, that non-blanchable. We still have tissue damage. So that's what happens. And now, obviously, things like your friction, where the skin's dragged over a surface, and not forgetting the skin kind of rubbing on skin. So that's also an area of friction we may not always think about. Doesn't cause pressure injuries per se, but it also will actually damage the integrity of the skin. And then obviously mechanical forces where the skin stays in place and while other tissues move. So a good example of that is putting the head of the bed up and the person sliding down. So that's where we see, certainly in adults, we see a lot of pressure injuries from that, because the skin sort of stays intact and everything slides. So those sacral pressure injuries are often caused by the shearing forces. Trauma. So important to think about trauma. One of the things that is traumatic to people is if they spend more than 2.5 hours in the operating room. That is just correlated with a high risk of pressure injuries. Extravasation injuries from IVs, and also pressure injuries from nasal prongs and those kinds of things. So the medical devices. Thinking about other things that may also affect your population are things like medical adhesive related injuries, skin injuries. So if you have someone who has a lot of tape put on them, you can actually really denude the skin from tape. And again, I just mentioned at the beginning the puncture wounds as well. Even having an IV or a needle inserted sometimes can cause issues. Circulatory, so things, obviously the obvious ones like venous or arterial pathologies, diabetes, limb paralysis. Important to think about limb paralysis and edema, and also venous insufficiency, because sometimes we very much undertreat edema from limb paralysis, because you've the loss of the muscle, the pump, the leg pump. So your lower extremity is basically the leg pump to get the blood back to the heart. So again, just watching that we manage that edema. Obviously, pathologies, nutrition is one of the pathologies. People who are undernourished will be more at risk for wounds, cancer, immune suppression. I mentioned pilonidal disease because pilonidal sinus disease is a disease of youth. And maybe later on we can talk about some of the other conditions that you may see that I'm not as aware of. The other part, the right-hand side of the person and family-centered concerns, are things that I think we all kind of think about, but again, they have a real relevance to pressure injuries or other wounds. So pain is really important. Again, I would say rather undertreated, not given pain medications regularly, which is probably my biggest beef with pain medication. ADLs, obviously, what they need to do, psychosocial well-being, having a child or a youth who's got issues and disabilities and is something that I'm sure you see lots of. Access to care, finances, and the substance uses in terms of their effect on wound healing or wound risk. Just wanted to go through this healability piece, just a few things to think about. Wounds will not heal unless there's good blood flow. And that the cause of the wound can be identified and corrected. So those are really important things. You need to manage your person factors, what's going on with the person, and then things like that the medical comorbidities can be managed and don't prevent healing. So and treatments can be accessed. So that's really something that's really important. Sorry, there's construction happening at my house, and I didn't put in my headphones in. I apologize for the background noise. Maintenance, vascular supply. A maintenance wound basically is a wound that will heal if everything is fine, but sometimes the resources are not available to treat the wound. Medical conditions are not optimized for healing. And in non-healable wounds, we have poor vascular supply and disease processes and stuff like that. So just thinking about those things when you are looking at a wound. Again, they're not discussed in any kind of great detail when we talk about wounds, but important to think about it. Again, I make the parallel between this and cancer. We would never tell somebody that has, that are palliative, that their wound, they're going to get better, right? And so, but wounds, we don't tend to have those conversations. And then just wound types, can talk a bit about which types are pertinent in your pediatric and your youth population in terms of things that you may have some questions about. So let's talk a bit about pressure injuries. I'm just gonna have a look at the time here, 8:32, okay. I know this is an adult, but this was a critical incident that we had. The story of this lady was that she had mental health issues and was admitted with a fracture in her toes. So the reason you see the bruising on her toes there, she broke her toes, and she was put into a cast boot and then transferred to another mental health unit in one of our sites, and nobody checked under her skin. So this is where I was kind of the fear factor, right, in terms of the fact that the staff didn't think to take off her boot. They were worried about hurting her fracture. So, but they were causing way more damage to her skin. So she came out with this pressure injury. So, so it was a stage 3, and so just questions really about what stage is it? What are the clues for the stage? The clues for the stage being a stage 3 is that it has slough in it. So that yellow stuff there is slough basically. And it's really important to think about the location, left, right, where is it on the body? Really important to think about that. And the one thing that the comment I got about this wound was it's not very deep for a stage 3. Well, it doesn't have to be deep. It's the top of the foot doesn't have a lot of adipose tissue. So it's down into the subcutaneous tissue, and stage 3s always will generally have slough. Stage 2s don't. So again, kind of your detective work here. So again, we talked a bit about the staging when you want to think about anatomy. So each stage affects a different layer of skin. So if you've got a stage 1, it involves the epidermis. Stage 2, epidermis and dermis. Stage 3, epidermis, dermis, and subcutaneous. And then stage 4, you're down into structures like tendon, muscle, and bone. And kind of important to think about where this pressure injury began. So, this is just there's some times here. This is done by Joyce Black. If you ever read her work, she's a nurse. I think she works out in Nebraska. She's an advanced, obviously a PhD nurse, but she's just a really practical person when it comes to pressure injuries, and sort of is comes with a great sort of sense of, you need to know more about this. And I like her approach, but you know, sort of where was the person when this began? So I'm sorry, this says resident. It was done for a presentation with in personal care homes. So, you know, turning may have been impossible. Operating room cases greater than 2.5 hours. Your client might have ended up in the emergency room. What happened there when they were there? So thinking about that. I mentioned this a bit before about depth. Depth varies by anatomical location. So places that don't have a lot of adipose tissue, bridge of the nose, the ear, the occiput, the heels will not be deep per se, but they will be into the deeper tissues. They will be into the structures. So depth is a hard one to talk about because you talk about deep structures being your tendons and your bones, but just making sure that you think about where it is and what the anatomy is in that area. So just a quick reference guide. I know that I sent some stuff to Liz in terms of a little enabler that we've done. So stage 1, intact skin damage. Stage 2, we've all had stage 2s when we've worn shoes that don't fit very well, or our feet have swollen. So it's a serum filter or ruptured blister with no slough. Stage 3, you'll get slough and eschar. So eschar is like the dark black tissue. Slough is yellow, gray, black. And then structures will be visible in stage 4, so bone, tendon, muscle. An unstageable is that you can't see the base of the wound. So there's a lot of necrotic tissue over top of the wound. A deep tissue is really important to be aware of. It's deep purple, blood blister. It will often declare itself as a 3 or 4. And because you would have people with all kinds of medical devices, it's on the mucosal membranes. It's not stage, it's called a mucosal membrane pressure injury. So that's sort of this quick reference in the quick look at pressure injury staging. And I also just want to remember that stage 1 is not very simple. It's often hard. So make sure that if you're looking for a stage 1, hold the pressure for 3 seconds. So what I always do is I count 1, 2, 3 on the red mark, and then I lift my finger. And in darkly pigmented skin, stage 1 presents as 1 or more of sort of like a blue or purplish discoloration. You have to look for temperature changes, maybe some firmness, some pain. So it's not, staging a stage 1 is not simple. Yeah, just remembering where the mucous membranes are and any devices that will be inserted into any of those openings. So basically a mucous membrane covers any opening from the body to the outside. And so medical devices will cause mucosal membrane pressure injuries. Just a little bit of, what to do, inspecting the skin under around the medical devices every 8 hours if possible. If you've got somebody who may have fluctuations in fluid or edema, a little bit more often. And then we actually have this new guideline that we put together in terms of preventing medical treatment related and skin tissue injuries. So that's the link to it. And it's on the WHA website. It's on the external site, so it is available. Yeah, heels obviously are big issues. Avoiding things like getting the heels right down on whatever surface it is and floating them, thinking about things that might keep the heels from getting pressure injuries. So there's these are the Prevalon booties that we have in the hospital system. You probably have some other products that you use. Oh, there's an extra slide. Sorry, didn't take that one out. And then just kind of the 24-hour approach to pressure management, which you probably know way more about than I do. So what considering all the support surfaces, that includes the commode, the bedpan, the bed, the chair, whatever it is, and how do you redistribute pressure, offload, and sort of transitional movements on and between surfaces, and obviously a lot of collaboration with your other members of the healthcare team. Okay, and now I'm going to open it for questions and discussions, but I am going to go and get my headphones because I didn't realize that they were going to be putting siding on the front of my house this morning. So just a second here. So I think I can stop sharing.